How's that? Someone give me a thumbs up. Yep, thumbs up. All right. Well, thanks everyone. I guess I have a little bit of mood lighting here in the background. It's kind of just got dark here in New Mexico. So thanks for the invitation to give a presentation. My background and story is that I essentially I'm interested in understanding why people do bad things. Not that dissimilar from Christine's summary. I grew up about a block away from Ted Bundy. And my dad was a writer, editor, and as I was growing up, I was just kind of fascinated by how could somebody end up doing things like that. And, you know, that's kind of snowballed into, you know, the work and the science that I'll, you know, summarize for you today. So what I'd like to talk a little bit about is what do we mean by a psychopath? And all of you probably have your own, you know, thoughts and feelings on the matter. And you've certainly probably seen a lot of TV shows and other things that would talk about psychopathy or mention individuals having these traits. And so, but these are, and there's obviously, it's a packed house tonight. I've got like 4 screens of people on here. And the traits of psychopathy have been around for a long time, or at least they've been written about for a very long time. So as far back as Moses, actually, individuals have been writing about people who have these very specific types of traits. For example, here, someone who's a wayward and defiant son, doesn't heed or listen to mom or dad, even after being disciplined, so fails to learn from punishment, and expresses and drinks a lot and is a glutton. Aristotle actually had one of his students wrote a whole book called The Unscrupulous Man, which talked about traits, including things like cheating, being a rascal, borrow and never repay, a thief, and incorrigible. And so throughout history, there are just a lot of different fascinating characterizations of individuals with these traits. And they're present in all aspects and in all cultures and in all races. And so even in, you know, various Nigerian, this is a Nigerian, the Yoruba, as it's called, the Nigerian pre-industrial tribe used this term Aranikan to describe individuals who always go their own way regardless of others, who are uncooperative, full of malice, and bullheaded. The Inuit also call them the Kulangata, for someone whose mind knows what to do, but he does not do it. They repeatedly lie, steal, cheat, and rape. And the Inuit actually have a very successful solution to this. They take these individuals and they put them on little icebergs and push them out to sea, is how they try to treat the condition. Psychiatry has been fascinated by psychopathic traits from the earliest days. And so Philippe Pinel, who was the director of the Bicycletra, which was this large psychiatric facility outside of Paris, always recommend go take a visit if you are visiting Paris. But he used to differentiate this group of patients that they would see who would be in all sorts of trouble and problems, but they didn't have any intellectual problems. They had no forms of psychosis and no delusions, hallucinations, or other command, you know, problems like that. But they were mean, antisocial. They used and abused a wide range of drugs. They're irresponsible and then immoral. And the immoral side of this is basically, you know, one of the central themes in understanding the evolution and the assessment of these traits is that they really just don't seem to have any appreciation or concern for the rights, welfare, and feelings of others. When we were forming our US criminal justice system, there was actually very long and complicated debates about whether or not we should have a condition called moral insanity to run parallel to what we refer to as normal insanity. So those that are NGRI are not guilty by reason of insanity for having issues with, you know, like psychosis or other types of problems. And there was a great debate, and it was some of the first psychiatrists actually testified or talked about how, you know, at the time studying intelligence or other types of issues, but that the moral faculty, that is our ability to make decisions or make right or wrong decisions, was something that could be damaged. And it was something that should be included in the realm of medicine. And it probably took close to, you know, 150 years before we flipped back and started to study these types of things now in great interest. And it's definitely a big area that my lab is focused on. And then this is one of my favorite quotes. It was by Henry Maudsley, a British psychiatrist. And he said, as there are individuals who cannot distinguish certain colors, having what we refer to as color blindness, and others who have no ear for music cannot distinguish one tune from another, so there are a few of us that are just congenitally deprived of a moral sense. And the point here is just to highlight that across cultures, across time, across disciplines, there's been a resounding appreciation for individuals who have these traits. And many, many, many people have written about this throughout history. We were fortunate that, in the late 70s, early 80s, there was a number of seminal meetings on psychopathy where all these different groups around the world got together at these NATO Advanced Study Institute meetings. And they essentially kind of created a consensus statement that these are the traits that we think are relevant. And Bob Hare, who was my graduate school advisor, went ahead and tried to develop an assessment procedure for doing this, because there's a lot of different ways that you can think about trying to assess psychopathic traits, and they all have more or less validity and utility. But the psychopathy checklist, this test that you see here, these items that you see here, they're assessed on a 0, 1, or 2-point scale. And 0 means the item doesn't apply to the individual, 1 meaning it applies in some contexts, and 2 means it most definitely applies in all available contexts and all aspects of their life or the majority of their life. So we're assessing traits. And in order to do this, you have to spend 2 to 3 hours interviewing. This is the fun part of my graduate students' lives, is they get to go in and interview all these guys and listen and talk and study and read everything that they've ever done and talk to them about everything they've ever done. And then you score them on these 20 criterion. And there are some that some of us think are more important than others, that might have a little bit more value in terms of their predictive utility, et cetera. But some of the central things are just this profound inability to experience or appreciate remorse or guilt. And they're very callous often about the types of things that they've done. And I could give you, we've only got about 30 minutes, so I can't give you like dozens of different examples. So I'll go through a few, but individuals that have these traits are quite different. You look at things like item number 15, many marital relationships, and you're like, wow, in order to have a score of 2, you'd have to be married 5 times before the age of 30, I think it's 35. And to me, that was really striking. And then you're like, my first 2 high scores that I interviewed when I was in graduate school, both had been married more than 5 times. And so it basically, indicates that they're willing to engage, they're willing to jump into a relationship, a committed relationship, with really no appreciation or concerns whatsoever about leaving that relationship. There's actually court cases that have tried to use psychopathy as grounds for annulment after being married and then trying to get a legal document that says you were never married. These traits don't just magically appear at age 20 or 30, or there's no onset like you might have in something like schizophrenia, 17, 18, 19 years old. Children with these high score on early behavioral problems are having, precocious sexual activity before the age of 12. They're engaging in delinquent activity before the age of 12. They're often arrested before the age of 12 or taken from the home by social services, even though the parents are taking care of other kids normally. And so it's very much a disproportionate kind of assessment. And it's extremely difficult to actually score high on these things. And so these traits range on a score then from 0 to 40. And so a 0 is an individual obviously has none of these, no aspect of this whatsoever. That's most of the women on this call, to be honest with you. Women generally score much lower on this test than men. The average US male population will score about 4 or 5 out of 40. Your average North American inmate is right around 20 or 21. And then, originally just for statistical reasons, one standard deviation from the mean, it was defined 30 as being the criterion for a high score, so 30 and above. And what happens in my lab is if you're sitting and we're talking about somebody, or I have everybody, I want to know kind of when do they think they have the prototypical, psychopath, the individual that has all of these traits. And I'll start like, do you know you have somebody at 30, at 31, at 32, at 33? And by the time you get to 34, almost all the hands up are raised. And that's a standard error above the error measurement in the test. And that means everybody's clearly really in the high range. And it's really easy to score people who are high and who are low. Like those are some of the easiest cases to score. It's much more challenging to score those that are in the middle because it might be a little bit of debate about how much of one trait or another somebody might have. But generally speaking, we score everybody. We videotape all of our tests. They're all double rated, typically by a handful of undergrads or others as you come through. And so this score has a lot of implications for lives of inmates. in respect to risk assessment, treatment amenability, and other types of things. And most countries around the world, especially through Europe, Canada, less so in the United States, but it continues to grow. It's not without controversy, but more and more states are using the psychopathy checklist to help in their risk assessment and stuff like that. So why do we care? Why do we care about this? I mean, it's obviously, some people find it, just like myself, intrinsically, interesting and fascinating and completely different from us. But the reason why it's gotten so much traction in the criminal justice system is that it predicts things. So these are called Cox regressions or survival curves. And so if I release you at the beginning, and I think this mouse may or may not show up there, but if I release 300 inmates and then I've divided them by low, medium, high psychopathy scores, what you'll find is that the percent of those that will reoffend that score high in psychopathy is upwards of 80% within a year. And that is impressive, to be honest with you. These are reconvictions in this data set. So that actually means that they started doing, half the sample started doing crime within the first 100 days of being released. And then eventually criminal justice system caught up to them and they got arrested and convicted. And then by the time you get out to even as much as 3 years, you can find that the vast majority of the highest individuals have reoffended. And this is typical. The average inmate about 3 years, about half of them have reoffended. But if you've got a client or you're working with somebody who scores low, 20 or below, then they're a pretty good risk, only 1 in 5 chance that they're going to actually come back in prison in a 3-year period. And so these would be individuals that you might release without any preconditions. These would be individuals you would release with additional conditions, and these guys probably need ankle bracelets so that they can try to keep them from getting in trouble. And psychopathy has actually gotten its traction because it predicts future violence. So this is another survival curve that goes out over 20 years. All these individuals had been previously convicted in Canada of a violent crime. And then at some point, because Canada has much less stringent sentencing guidelines, they'd been released, and then they were followed over the rest of their lives, basically. And this is percent of those reoffending with a new violent crime. And as you can see, again, those that are score high in psychopathy, essentially within a 7-year period, 80% of them are back in prison for a new violent crime. And it's not so good news for these guys either. I mean, this is about half the sample is going to be reconvicted of a new crime. But the relationship between psychopathy and future violence in terms of predictive value is about 0.39. And to kind of ground you, that's like the relationship between chest pain and having a heart attack is like 0.15. And so this is a very significant predictor. And to my knowledge, there's no single predictor that has as much explanatory power as psychopathy does for predicting future violence. Age is certainly a very big predictor, but after controlling for some of those basic variables, psychopathy is still one of the best predictors. And so that's why a lot of countries mandate its assessment for all of their offenders in order to try to help understand whether or not they're dealing with somebody that's high or low risk. Data suggests that you can measure these traits as early as age 13 and 14, and they still predict. So this is again showing like a doubling of risk for those that score high in psychopathy, for those that score low. Again, all boys who have been convicted of previous violent crimes and now are being convicted of future violent crimes in these analyses. So these are all prospective studies. Psychopathy also has important implications for treatment. So this is kind of showing the same data. So this is a higher rate of reoffending for those in an untreated group that have psychopathy or score high in psychopathy versus those that score low. And, that's a rough 30%, 20 to 30%, decrease or increase if you have high scores. And this treatment program, although not one that is particularly used today and was certainly be considered a non-conventional, found in effect that those that score low on psychopathy was actually a 50% reduction in violent crime. And then they looked at their psychopathy data. Oh yeah. So this is called iatrogenetic. This is an example of where the treatment may have caused more bad behavior than was already existing. And there certainly are problems with this paper, this analysis, but what it highlights is that, and this is borne out in every clinician and individual that I meet with and talk to about trying to treat these individuals, is that they don't generally respond to most forms of treatment the way that others do that score low on psychopathy. So you really have to consider these individual differences when you're thinking about developing a treatment or planning a treatment. And you might not get this, inverse effect, but you can certainly have problems when you have individuals that have these traits and they're not put in programs that are really tailored or specifically designed to help address the issues that they bring to the table. And so this is a slide that when I was teaching at Yale, a faculty member presented this during grand rounds. And I don't think you guys might all be familiar with it now, but 20 years ago when I saw this slide, it was surprising because all of the research that we've been doing had generally been showing that these green areas that you're seeing here, so essentially the circuitry that Brodmann described as paralimbic, which includes the insula, parts of orbitofrontal, temporal pole, the entire entorhinal cortex, cingulate, and amygdala down here, our friend, of course, that you've heard Christine talk about, that this circuitry had similar types of cytoarchitectonics. And of course, there are many other ways today that we can break these things up. But suffice it to say, in all of our studies that we were doing, we were finding that it was these green areas that were showing abnormalities related to psychopathy. And so this became a theory that psychopathy, if genetic or if some sort of an and/or environmental, was definitely causing problems in these areas. And to contrast that, not the pink areas, so not parietal, not orbitofrontal, prefrontal cortex, but those are areas that we generally did not see that were related to psychopathy. They're certainly related to other problems, but not psychopathy. And then, of course, you've already heard about Gage. And so I won't go back through and summarize all of the issues with Gage, but there has been a tremendous development in neuropsychology and following patients who've had damage to stroke or orbitofrontal and stuff like that. And we now know that this acquired psychopathic-like behavior can happen when you have bilateral damage to either orbitofrontal or anterior cingulate. So both of those circuits or regions, if damaged, will elicit the pseudo-psychopathic-like behavior. And but I wouldn't in any way call Gage or any of these patients really psychopathic. In fact, when I compare my psychopaths to the neuropsychologists or the neurologists that have been studying and working with these patients, I got an email today from a guy who wanted to chat about this. They're not ever even close to a high score. They might become irritable, aggressive, or have other problems or issues that are related to some of these traits. But we've never really met anybody that has an extremely high levels of psychopathic traits. Although Diane Swick and I continually will have a beer at CNS or something like that, where we'll talk about this one patient that she has that has bilateral anterior cingulate lesion, who probably scores in the moderate range, definitely something that would cause concern if you happen to be interacting with that person. But it's very challenging to get from a stroke the entire manifestation or even the majority of the manifestation of the traits related to psychopathy. And damage to these other areas is generally fatal. So there's rarely damage for people survive posterior cingulate strokes. Occasionally you'll get some mid-cingulate strokes, and then amygdala, or you can get a variety of different ways of studying and involving and looking at the amygdala. But the neuroscience that I'd like to talk about tonight that we've done, I'll summarize a number of different techniques, but for those that don't do imaging, this will just be a short slide. So what we do is we can obviously take a quick structural exam. Most of you have probably had at this point in your life been scanned in somebody's study. So you'll have a nice T1 image, T1 weighted image of your brain. We'll do some spatial normalization to get everyone's brain in the same space. We'll pull out the gray matter, so we'll segment this. We'll do a step to preserve concentration, a little bit of spatial smoothing because these steps aren't perfect. And then we have a bit of data in every bit of your brain that has a lot of value in it. In fact, I started in this area and in functional imaging, and now my lab has kind of come back and we continue to do more and more analysis of the gray matter data with much more sophisticated methods. And we continue to learn new stuff like all the time. And it's one of those things that's much simpler to analyze because it's just, it's just a single image rather than 10,000 images that we get from functional imaging and all the time series and other types of issues. And so, for those that haven't seen this stuff before, this gray matter analysis that we can do is extremely sensitive to things like age. And so you guys are all around here. I'm way down here, unfortunately. So what we're showing just here is simply a correlation with BA10, showing a negative correlation and gray matter loss as you age. And that's true. This is basically showing that the entire cortical ribbon shows a negative relationship with age. And so we tend to see that. And it's about 40% of the variance in gray matter volume, gray matter density, these different measures and ways you can quantify it is accounted for by the aging process. But we've actually developed, and I don't know if there's time tonight, but we've developed, and many others have developed measures of what we call brain age. And so we can actually compute, take your age and then identify regions that are different from where your age is. So you might look older or look younger than what your chronological age is. And that has a lot of value in predicting future behavior, even antisocial behavior. And then of course, there are some regions that show positive correlations with the age. So you guys all know what these different structures are right here. So this is your hippocampus. And as you stuff more and more memories, like these lectures tonight, into your brain, you're gonna thicken up that corpus, or that hippocampus. And we can actually quantify that with this technique. And then of course, you see a lot of other different areas, a lot of the cerebellum. Always be interested to find if there's any students now studying the cerebellum. We never really study it as imagers, but there's a lot going on down there that's particularly, I think, is really interesting. And so this is just to highlight kind of some of the ways that we use this imaging technique, or this quantification of gray matter, to help understand, different structures. And then of course, if this is who you're studying, Hannibal here. Anthony Hopkins is actually a very, very nice guy. I've met him once. But his portrayal of Hannibal is one of the most classic in film. And if you haven't seen Silence of the Lambs, then that's your homework assignment. But if you remember the movie, saw the movie, you remembered what happened when they tried to bring him out. So how do you go about studying the brains of these guys? And you could transport them. And if you remember the movie, you know what happened there. And we did that when I was a student. We actually worked with the Correctional Services of Canada, and they transported, over the course of 3 or 4 years, 50 inmates from a supermax facility, an hour-and-a-half drive from in these vans, from the prisons out to the university hospital, and we scanned them. And this provided, some of the very first studies looking at the psychopathy, functional imaging, structural imaging, even a little diffusion back then. And but I knew that, only being able to study 50 subjects in an imaging study over 3 years wasn't likely to lead to tenure. And so eventually, one of my life goals was to acquire this system. So we have I have a trailer. I live in New Mexico and I have a trailer. It's a very nice trailer. Inside that trailer is a Siemens 1.5T 32 channel advanced imaging system, an Advanto it's called. And with that system, we actually go to we generally go to about 10 prisons, 5 in Wisconsin, 5 in New Mexico, Wisconsin, where we have collaborators and sites set up. And then it also roams around for all sorts of criminal cases. So I'm married to an attorney, and she runs a group that teaches other attorneys how to do better science. And so a lot of criminal cases involve types of problems. So we run this thing around the country for those special cases and scan inmates right in the prison. And the wardens love that because they don't have to worry about transporting or doing anything else. And you can literally just pull it in, park it, plug in a generator, and scan. And so since we've had this thing deployed, we've collected a lot of data. So it's actually over 4,000 now. We've been halted by COVID, but before COVID hit, we've been able to basically study all these various populations. So thousands of men who are incarcerated. We've done about 500 women at this point who are incarcerated in 2 different prisons. We work a lot with maximum security incarcerated youth. So these are not kids that are, in county facilities for spray painting something. These are kids that are serving multiple years for felony convictions. We work with a very special population known as civil commitment. So 22 states provide for additional detainment following criminal sentence length or ending, and considering you to be a dangerous sex offender, and they sentence you to a civil or indeterminate sentence until you're cured. That's a very expensive process, and we've been interested in studying. They're basically considered some of the highest risk sex offenders in the world. We also work with forensic psychiatric patients. So these would be more of your standard psychiatric patient, but that has had interactions with the criminal justice system and landed in some sort of a forensic facility for breaking the law. And of course, what we were interested in doing initially was kind of testing the hypothesis that these regions that you see here in green are abnormal. That is, they're going to be different in individuals who have really elevated levels of these traits. So as you do, you get together and you write a grant and you get your first R01, and then you go out and you collect 4 years of data with this machine, and then you bring in a good postdoc, and the postdoc comes in and says, well, I'd like to analyze, that data and test this hypothesis. And her name was Elsa Ermer, and she came in and did one of the first papers for us. And what she found in the first paper was there about a 5 to 7% decrease in gray matter in the regions that you see here. So this obviously includes most of the paralimbic circuitry. So this is, medial anterior temporal lobe, amygdala, hippocampal regions. There's much of the orbital cortex, and in fact, extending all the way out. You had parts of cingulate and posterior cingulate, and then this temporal pole here was also different. And as you think about this kind of data, you're like, well, it's fascinating, really. It's only like a 3 to 5% difference, or 5 to 7, I guess it was in the study. It's a large sample, so what you're seeing here is a negative correlation between psychopathic traits and gray matter volume after controlling for all the things you need to, like substance use, IQ, age, education, etc. And almost exactly as predicted. So it's one of those rare times in academic life when something really turns out well, and one of your students or postdocs did a great job, doing the analysis, and then presents this, writes it up, gets it published nice and quick. And then it raises, of course, as many questions as we thought we answered. And so one of them is that, how did this get this way? So the next question would be, well, we could look at longitudinal work. We could try to decide, what else could we do? And what we did was, the next study that she did was an analysis of the boys. And so you guys can play a little pattern recognition, people here. So that's the adult male study in the top left. And then the bottom is adolescent boys. So this is about 200 maximum security incarcerated youth stratified by their psychopathy scores. And you'll notice that there's some striking similarities. So you have medial temporal, orbitofrontal, posterior cingulate, temporal pole, and nothing else, right? So there's nothing else in here. It's not mass data by any means. And so everything's being shown. And so this is some striking consistencies. It's about 500 subjects between these two samples. And what's interesting is that this doesn't appear to be an aging effect. So we don't see any increase between age 15 and age roughly 34, I think, this sample. And so these areas don't appear to be like atrophying because they're living a chronic, unstable, or antisocial life. So it definitely appears to be something that they're likely manifesting very early in life. And not to leave the girls out of the equation, we had only 49 girls in this study. And so at the prison that were able to volunteer. This has been out for a few years now. But again, what you're noticing is that medial temporal, orbitofrontal, didn't find any other evidence of cingulate differences in the sample, maybe because of power. And then there's some interesting stuff going on in the cerebellum. This is actually, when you give these lectures, you find out that somebody knows something about the cerebellum and they come talk to you. Then this is actually part of the limbic cerebellum. There's a part of the cerebellum that is considered to be, have emotional and other types of processes localized to it. So haven't really explored this in any more detail. And we're working on filling out the top grid by publishing the studies in the adult women. But I won't tell you it's the same. They look very much the same. And so this is, again, I think it's important to highlight that, this is it's close to 1,000 subjects across, or 500 subjects in these studies across all of these different analyses. And they're showing very consistent results. And I think that highlights that, not all of psychology has a replication problem. When you spend 4 to 6 hours interviewing and assessing somebody, and I think one of the take homes I'd like you to from this talk is that you're only ever as good relating your neuroimaging data to something that is really carefully assessed. So if you're really interested in IQ, you need to measure like the most robust IQ measure. If you're really interested in emotional intelligence or something like that, you really have to spend the time to carefully assess those traits and constructs so that you can try to relate them. And the more accurately you measure your psychological construct, the more likely you're going to be able to find a neurological or a neural correlate of that. But if you try to spend your time using like a self-report test or something quick and dirty and easy, don't be surprised that you need to have like 200 subjects in order to find an effect, because you're going to have a lot of variance there. So I really emphasize in my lab assessing and doing very careful clinical work in order to try to make sense of the neuroscience data. And in fact, when you ask like, machine learning algorithms, so we had a paper we published a few years ago using some more advanced methods than we originally published. And we got about an 82% accuracy for classification in the boys down there for high versus low. And the adult data didn't classify as well. And I think that's because, well, some of them have 20 or 30 years of cumulative drug abuse and lots of other dietary issues and head injury and all sorts of other types of things that I think we haven't been able to fully decode yet. But in the boys, we were able to achieve a reasonable level of single subject level classification using psychopathy scores, and that's versus the low score, so high versus low, so kind of taking extremes. And that's pretty impressive, but it's not atypical in today's work to see about an 80% classification for a well-measured, psychiatric construct. Now, I was going to talk just about psychopathy, but after kind of reviewing the slides and things and your discussions, I thought I would talk a little bit about a few other areas of work that we've dabbled in. And then, of course, happy to talk about any of our work with our questions and answer period. But unfortunately, as you all know, years ago, there was a terrible, mass shooting at Sandy Hook Elementary School, and the parents who lost their daughter, Abigail, Jennifer and Jeremy Richmond, they created a foundation in honor of her name to try to help fund research that was at this bridge, at this intersection between violence and mental health. And the National Institute of Mental Health said they weren't really interested in funding anything related to violence. That was the purview of the National Institute of Justice. And the National Institute of Justice said, well, we don't fund anything related to psychological research. So we've been working for years to try to get them to bridge these gaps and fund work that looks at these intersections. And so this foundation was created to try to help raise funding and then fund researchers, who wanted to do this type of work. But during my conversations with Jeremy, he came to me and he said, you have the largest collection of people who've killed other people. Can you tell me, is there anything different about men or boys who've killed someone? And I'm like, well, motivations for killing and reasons for doing that there's a myriad of different, ways and reasons why. And so it's not great psychological construct, murder, being a murderer. But, when these things happen in your career and you're asked by a family, especially a family of something so tragic, you say yes. And so I went back to my lab and my students pulled up a database and we watched all the films of all of the boys and we found 20 of them. There's 22 originally, but we had to toss 2 because they moved too much. And we found 22 boys originally that had committed a homicide in our maximum security youth sample, and 135 of their peers who were otherwise, same. And some of the peers, they took a shot at somebody and missed, and we didn't count them as homicide, even though they probably should have, because we were trying to study like intent to commit homicide. What we did though is then Laura Cope, one of my students, went through and did a VBM analysis and found that strikingly, the boys who committed homicide, even after controlling for psychopathy scores and substance use scores and other types of issues, they were strikingly different. In fact, the machine learning was over 85% correct in single subject classification of the boys who committed homicide versus the other boys in the system as normal. And that was kind of surprising to me that we got such a high classification. But then as I thought about it and, drank some beer and it's late, so I'm having a nightcap. We realized that what we might be measuring here is something that is a little interesting. So in psychology, we are really not very good at measuring outliers. If I have an IQ or I have a client that has an IQ in the 160 range, I could give them 4 different IQ tests and the scores would range from 120 to 180. So none of them are going to be perfectly accurate about measuring that high risk outlier. So when we have individuals here who score from 0 to 40, and it's easy to score the high ones, but what if their true score is 50 out of 40? So our test doesn't capture the variance for those that are extremely high risk. And these boys that committed homicide are extremely high risk. And so what the MRI does is it doesn't care. It just is the data. And so if you can decode it, then it's going to help you potentially explain, some of these phenomena. So I think what we found here, and on all of the regions that you're seeing there are different, are also typically, related to psychopathy. So I think this is just the leftover variance that we didn't capture well with our psychopathy assessment, even though we spent a lot of time on it, but the imaging data did reveal that. So these kids are even farther down the spectrum than our test was, and the imaging data helped us be able to do that. But it was extremely sensitive to these group differences. And then you get, fortunately, sometimes in your career, you get these really motivated, post-backs that come through, and in my lab, they actually make a decent salary. And they come through and they code 1,000 inmates, adults. So Ashley, who came through my lab, went through and sorted through public records, querying over 1,000 inmates. So this slide here just shows you 216 adult men who committed a homicide. And we're not talking about drunk driving or any of these other things. And we compared them to men that had committed a violent crime, but not a homicide. And there's multiple other comparison groups in the paper, but every single region that we found in the boys that was different for homicide was also different in the adult males who committed the homicides. And there were other areas too, because the sample size is obviously, 10 times bigger. And so it just was striking to me again that you find, and this is also includes some different areas that we don't see related to psychopathy, like some prefrontal areas, but that these areas that that are different is that individuals who are willing to commit these crimes, and again, we haven't gotten into great detail about the motivations for the crime or was there something different, but these are individuals who are convicted in a court of law of, voluntarily committing a homicide. Their brains are different. They're quite different, measurably different, and it was quite fascinating. And so this just highlights, I think, some of the different, studies and issues that we've been tending to see in our analyses. And I didn't put up a lot of the functional imaging work that we've done. In 30 minutes, there wasn't a chance to review, the dozens of papers that we published in there. But we also look at like network connectivity between all these different nodes, and have published a series of studies identifying trait-related both functional connectivity as well as dynamic connectivity and even dynamic network connectivity differences between those that score high in psychopathy and those that score low. And I had one other case study I'll share with you guys, which is kind of interesting because we've also published that the uncinate fasciculus is impaired in individuals that score high in psychopathy. And the uncinate fasciculus is a region of the brain that connects the anterior temporal lobe to the frontal lobe. So this has become the circuitry between the orbitofrontal, and temporal pole has become a very significant interest in my team, because it always appears that regardless of the study, the sample, the population, that's the circuits that really appear to be implicated. And so this is another example of what can happen. So this was a case that I worked on. The guy's 47 years old, and he starts off getting some problems. He punched a hole in the wall at work where he'd worked for almost 20 years. They fired him. His girlfriend left him because he was getting angry and irritable. He forgot to pay his bills, so he got kicked out of his apartment, and he moved back home to his parents' house, living in their converted kind of garage as a bedroom. And he's going to see his friends, and he goes and visits them. They get in an argument, and he goes in, he gets a gun out of one of the room, comes out and kills three people. And as I sat there and interviewing him and talking to him for 3 or 4 hours, it became clear that he was suffering from some subtle concerns, paranoia, a little bit of psychotic symptoms. So I left, I went out and had In-N-Out Burger, I came back, and I went and kept talking to him, tried to tire him out, tried to get him a little worn down so that I see if he could precipitate some of these symptoms. And sure enough, after 5, 6, 7 hours of talking to him, it was clear, and he started to express that he had some pretty serious classic paranoid delusions. And in this case, the prosecutor was seeking the death penalty. This happened to be in an area that there weren't a lot of Caucasian homicide offenders, and this was someone who had committed this crime. And because most of the death penalty cases in the state were minorities, this prosecutor really felt they had to prosecute this case to the death penalty. Well, fortunately, when death penalty litigation is engaged, it provides a lot of sources of funding to pay for scans and other types of things. So we took this client to local 3T and got him scanned. And when you see this type of damage or this type of atrophy bilaterally in the anterior temporal lobes and part of the frontal temporal dementia. So this is what's known as the behavioral variant of this very incipient, terrible disease. It's called the behavioral variant for a reason, because the patients who suffer this condition often have pretty severe aggression, other types of problems. Obviously, this one ended very badly. But he was immediately, adjudicated as not competent to stand trial, sentenced to the state hospital for an indeterminate period of time. He subsequently has passed away. It's a terminal disease, but it happens really early. So there's, he has no history whatsoever of these symptoms or problems before the last year. He's too young for what you would typically think of as a degenerative condition, but this thing appears to be, and we think it's probably more common in our prisoners. And so we've started to look more carefully and have all of our scans reread by a radiologist trained to look for these, because these are the areas that we generally see a lot of problems in those that score really high on psychopathy. And so that's it. Now, am I done on time? Did you want to move to questions, or did you want me to give some more examples?
I think we can move into questions.
All right. Well, I want to.
That's all right.
That's fine. Yeah, I want to make sure that I thank everyone. I send a lot of people to prison, and so over the years, I've been fortunate also to collaborate with a lot of great people, and been generously funded by various NIH, mechanisms. And I'll shamelessly plug my book. If you're really keen to listen, you can watch the audiobook, or you can buy the book. But if you want to hear about all of the development and a lot of other science in this area, a lot of one-on-one interviews with really bad boys, I've written about that, and it was quite fun to write, actually. And I'll thank you all for your attention, and I'm happy to take questions. Are we going to try to have a moderator do the questions?